Good day, and thank you for joining us here at the International Myeloma Foundation's Regional Community Workshops, Southwest. We welcome everyone that's here, and we want to talk to you a little bit about some things about the IMF, and then we'll go on to the doctors. Next slide, please. Well, we got a couple of things that we have to do for housekeeping. My name is Kelly Cox, and I'm the International Myeloma Foundation's Senior Director of Regional Community Workshops. The housekeeping is this: please put your mic on mute, and we'll take care of that. Sometimes you can turn your camera on and off, but we prefer that you leave it off for bandwidth. Second to that, over to the right of your screen, you'll see a box there that says, it's a chat box, and what you'll be able to do is ask your questions in that. Let's try to wait towards the end and listen to the presentations. We are thrilled to have Dr. McHale, Joseph McHale, and Nina Shaw. These two doctors work very, very hard, and I appreciate them coming on this weekend. And finally, before we get going here, I'd like to thank our sponsors, who are Amgen, Karyopharm, Bristol Myers Squibb, Janssen, Takeda Oncology. Without them, we couldn't do some of these programs that we do, and we're incredibly grateful for that. You see myself there. It's Kelly Cox on the left side of your screen. There's Joseph McHale. There's Nina Shaw and Kimberly Noonan. They have been doing this kind of thing for several years, just without COVID, but we're all protected from COVID and we're separated. So I'd like to go with Dr. McHale to get going with his talk. Oh, I forgot about this part. Thank you, Amira. We're going to get through this welcome and announcements for myself. Then we'll go into disparities in myeloma, then Myeloma 101 and frontline therapy. Now, if you think that you've seen all these things, you can always learn from every program that you attend. So get your notepads out. Let's go into the next segment. Then we go into relapse therapy and emerging therapies. Then we go into questions and answer sessions with the panel. And then finally, we do Navigating the Journey with Kimberly Noonan. This is a great slide deck, and we look forward to you seeing them all. And why don't we start? Is that it for all my stuff? Great. Let's start with Dr. Joe. Woo.
Thanks so much, Kelly. You're very kind. It's always a pleasure to be a part of this. We've listed, here's my title. I'm at TGen and my academic appointment, but for those of you here in the Phoenix area, you know that my clinical practice is at Honor Health, at the Honor Health Research Institute, where I see myeloma patients several days a week now, it seems, keeping us very busy. And it's just a real pleasure. And thank you for joining us today. We really hope that today is going to be very practical and helpful. Kelly has been the king of regional community workshops for, I'll be gentle, Kelly, for more than a few years. And
thank you.
These are typically quite a significant portion of the day. Obviously, we've curtailed it, so it's more reasonable for you, but we really hope it's going to be helpful, and we look forward to your questions. I'm just thrilled and delighted that Nina Shaw is with us here from UCSF and Kimberly Noonan. These are two of the people that I respect the most in the myeloma community. I've learned a great deal from both of them, and I trust you will today, too. Before we talk about the basics of myeloma, what we've often called Myeloma 101, and how we approach early therapy, I just really thought it was important to address this issue of disparities in myeloma. This is a topic that has always been relevant, but I would suggest has been particularly more relevant recently as there have been more and more research done in this area, a greater understanding of the significant disparity that we see in myeloma. And furthermore, the IMF has always been committed to this issue and this topic. And recently of late, we've even further redoubled some of our efforts in the area. So the IMF has multiple diversity initiatives, has always been very keen on empowering all myeloma patients, independent of race and background and circumstance. But of late, it has really been something that I think has been on all of our minds. And I wanted to share with you a little bit of how we've approached this and some of the relevant ideas I think that are connected to this. The first is getting some definitions correctly. And there's no perfect definition, and people definitely feel differently about many of these topics. But to keep us on board and fairly straightforward today, let me suggest these three definitions. That equity, which of course is different from equality, that equity is a means to guarantee fair treatment, access, opportunity, and advancement for all, while we're striving to identify and eliminate those barriers that have allowed full participation. Whereas equality is, if you will, giving everybody the same. Equity is trying to bring everybody to the same level of excellence. And we all know in myeloma in particular, this has been a tremendous challenge where certain individuals don't have access to therapy or have bias against them, be it unconscious or conscious. Diversity and valuing diversity is that we recognize and respect everyone's unique qualities and attributes, not that we just accept them, but actually we value them, we embrace them. That this is, of course, what makes us better in this diversity of thought, diversity of background, etc. And then lastly, and perhaps even most importantly for our discussion today, is the concept of inclusion, that we make all individuals feel respected, accepted, and valued. And one of the things that I know will come through in our discussions, and I've witnessed it firsthand with Nina and her patients and Kimberly and her patients, is how important it is that we develop a relationship with our healthcare provider. If you're here listening today and you're a patient, if you're listening today and you're a caregiver, if you're listening today and you're in the healthcare profession in any capacity, that special relationship between a patient and their healthcare team is fundamental and influences. We have evidence in oncology now that actually influences not just better, if you will, quality of life or adherence to medication. It actually has an influence on individuals' survival. So it's really, I think, an important topic. So as I've mentioned, the IMF, and I'm not going to be able to spend a lot of time on this today because we just wanted to give you some of the highlights, but that we have been very much involved in this subject in multiple continents around the world. We have a global myeloma action network, as we call it, the GMAN. We have over 160 support groups right across the U.S. and many in Europe and the Middle East and other places. We have had very specific and dedicated activities over the last, or actually really the whole 30-year history of the IMF to African Americans, Hispanic Americans, Asian communities, and many, many more. And then also trying to identify and eliminate those barriers, as I indicated, to vulnerable and disadvantaged individuals who may have a different form of insurance, individuals who, as we've learned through COVID, may not have Wi-Fi and bandwidth that allows you to have a telehealth visit with your provider. So many of these things are what we've been doing in the past, and you can see more of it on our website there at myeloma.org/diversity, but also that we are moving forward and doing even more. And we've created what we're entitling now at least a diversity inclusion team that oversees the aspects of all of our initiatives, of which there's one initiative that I'd like to just spend a few minutes talking about before we get into our myeloma lectures, which is our African American initiative. And it fits the modality of the IMF. The IMF is always involved in advocacy and engagement of individuals, education, support, and research. And I think you'll see much more detail about that in the future. So building on this background, we've created a program, deepened our programs within what we're now calling our African American Initiative. We know that many have sought to try and do this, and sometimes there have been challenges, but we've learned a lot in the last little while. And maybe if I share with you some of those key facts, it may help you in your understanding of this. And I sometimes call it my top 10 facts regarding African Americans and multiple myeloma. And this is coming from a man of color, and technically I'm an African American by virtue of my parents' descent. And so I'm very passionate about this and very interested in bridging that gap and of bringing equity to a situation where there has not been equity for many, many years. The first is that myeloma is the most common hematologic malignancy in African Americans. So indeed, MGUS, as you're going to hear described in a moment, and myeloma are twice as common in the African American population than they are in the Caucasian population. So this disease is significantly more common. And although Nina and I in particular are going to be sharing with you some of the great advances we've seen in myeloma, I mean, I can really not think of other cancers where we have doubled, if not tripled, the average survival of patients in the last decade to 15 years. We've seen these great improvements in survival, but we've not seen the same degree of improvement in the African American community and, frankly, even in the Hispanic community. So, for example, for every 1.3 years that we've added of life on average in the myeloma community, in the white population, we've only seen a 0.8 benefit in the African American population, so just over half. So that's really woefully low and needs to be addressed. On average, African Americans are younger at the age of diagnosis. The age of diagnosis of myeloma tends to be in the late 60s, maybe 68, 69. And so it's significantly earlier in the African American population. And one very clear reality that we've experienced in our surveys of myeloma patients, as you know, the IMF is connected to myeloma patients around the world and many, many here in the US, that there has been this consistent reporting in the literature and in our surveys and our interactions that there's a longer lag time between the introduction of symptoms, because often other diagnoses are considered before the diagnosis of myeloma, before an African American patient is accurately diagnosed. And then when it comes to treatment, unfortunately, we're going to be hearing about the importance of triplet therapies and combining different agents together, that unfortunately African Americans are less likely to have triplet therapies. They're less likely to have stem cell transplants available to them, and they're significantly less likely to be participants in a clinical trial. African Americans comprise nearly 20% of all myeloma patients in this country, and yet we only see about 5 to 6% representation on clinical trials. And so this is clearly something that we need to address with time, and we're working very much at the IMF to do that. And then lastly, a couple of final points that really is the impetus to do so much of this. We know that there are biological differences, that there are certain, as you're going to hear today, about high risk and standard risk myeloma and different cytogenetics or genetic abnormalities of the disease, that this can be different. And perhaps most importantly is number 10. If you've been not hearing this all, this is really important. From a very large veteran affairs study done and published this last year, when African Americans and Caucasians were treated the same, so in that system where everybody, at least theoretically, is given the same access to treatment, that the survival outcome was not only matching that of Caucasians, but actually better. So we have a mandate here. We have an opportunity to do so much better in this community. And so we're very committed to doing that. And so we've created this African American initiative. And I'm not going to go through it in a lot of detail, but our vision is to improve both the short and long-term outcomes of African American patients through 3 major mechanisms of engagement, of education, and of support. We've really been able to expand this concept geographically, and we're very excited about some of the work that we can do. As you'll hear from Kimberly shortly, this is a phenomenon that is not only reflected in the physician, if you will, community of myeloma, but in the nursing league as well. And so we have our nurse leadership board here at the IMF, which has been a tremendous resource to patients and nurses across the world. And so the nurses have also been very much engaged with this and have actually developed their own documents and approaches and best care practices to share with other nurses, to have us understand the unique features of different populations, not only the African American population, but of unique populations, and how we approach them and how we can do our best to build trust, to have multi-ethnic teams, to engage the community, and to express cultural competence. And if you're not familiar with the word cultural competence, I suggest you Google it later, learn a little bit about it so that it can influence the way you think and approach. Because very often the problem here is our thinking, even unconsciously, we can express bias that we don't fully understand at our first pass. And so, for example, they have created a wonderful document. I know it's not legible here. I just wanted to give you the sense that this is a very recent publication that both Amy Pierre and Tiffany Williams have recently created and published, really trying to look at optimizing care so we can decrease racial disparities and what are the best nursing practices in this realm. So that's all I'm going to share with us today. There's so much more that we can discuss, and later on I'm happy to address any questions that may arise around this. But I thought it was important today to start this wonderful program to realize the extent of this challenge, but also how we want to do everything we can to approach it. This is one of my favorite slides I tend to end my talks with, which is this idea that it's the I in IMF, the International Myeloma Foundation, and it's such a pleasure to be a part of the myeloma community. In the pre-COVID days, I typically spend almost a third of my time in the third world trying to find ways to build collaborations and obtain ways to get these fantastic drugs that we're going to be discussing today to poor people in poor countries. And it just is such a privilege to be the Chief Medical Officer of the IMF. to be able to try and do that. So I'm going to stop there with respect to our first discussion when it comes to the disparities in myeloma, and I'm going to move now directly into our first talk with respect to myeloma therapy, where we'll first do what I call myeloma 101, so a little bit of a primer in myeloma. And I really liked how you said, Kelly, earlier that you could be here today and be an expert in myeloma, and you've been, whether you're a patient or a caregiver or in the healthcare profession, we can always learn more. And so I'm hoping to prime the pump a little bit here and then dive into how we approach myeloma in the frontline therapy, because this is a rapidly changing field. And then when Nina joins in later and talks to us about relapse therapy, you'll see it's even more rapidly changing as we go through. So I just want to review some of the very basics, because we know when we host these regional community workshops, and I mentioned Kelly is the king of workshops. Many of you are very new to this. The word myeloma up until a few weeks ago was not in your vocabulary. Isn't that a skin thing? You might have thought. And so we're going to try to do everything we can to bring you up to speed, to review some of the basics, define what multiple myeloma is, and then specifically focus in on initial treatment and how we approach this condition. So I'm a hematologist, I'm a blood doctor, so I don't want to make it sound like I'm gory, but we're all a little bit obsessed with blood. And so we think of it as the most important organ in the body. What use is the heart unless it's pumping blood, right? It needs blood to pump. So it is a critical organ. And it's kind of made up of two bits, the liquidy bit that we sometimes call the plasma, and then the bigger bit are the cells. In light of the fact that I always make analogies to just about everything, we have 3 cells in our blood that are much like wine. It's a little bit early in the day for that, but we have white, red, and rosé, right? So we have these red cells, and I want you to think of red cells as basically little red trucks. I know, sorry, Nina, I'm offending every hematologist in the world, but basically red cells are little red trucks. They come to your lungs when you breathe in oxygen, they pick up the oxygen, and then they go deliver them to the tissues, to your brain or other organs, drop off the oxygen, go back for more. And that's all they're doing. They're just driving all day long. Pick up, drop off, pick up, drop off. White cells are a little bit more complicated. Think of white cells like soldiers in an army. They form an important part of your immune system. In fact, there are 5 kinds of white cells, just like there are 5 branches of our military. And so they are very much involved in protecting you. And obviously, through this COVID pandemic, we've been hearing so much about the immune system and antibodies, and we're going to come back to that in a moment. But our immune systems are critical to protect us, and that's what your white cells do. Thirdly, we have what are called platelets, or I think of as the rosé cells. These are smaller cells, and these are ones that help you clot. So if you have a cut on your arm or your hand, the first thing to get there plugs up that hole and stops the bleeding. It's kind of like, I think of it as the ambulance. It gets there first. It sort of deals with the problem until the further what we call clotting cascade can come and form a really strong clot. And all 3 of these are made in the factory of your blood, which is the bone marrow, which some of you know all too well what it's like to have a needle stuck in your backside to understand what a bone marrow is. But these 3 cells are made in the blood. So it's one thing to look at a blood test where we can find those 3 cells. But it's another thing to do a bone marrow test, because when we do a bone marrow test, then we can see so much more of what's going on in the factory. Just like if there's a car factory, I can see the cars that have come off the assembly line and that are in the parking lot. That's great. But if I really want to understand the factory, I got to go inside of it. And I see the rubber and the metal and the working conditions of that particular car factory. And so when your physician or your healthcare team orders a bone marrow test, we're diving into the bone marrow. So what is cancer then? And how do we talk about cancers of the bone marrow and specifically myeloma? Well, simply put, cancer is identical, uncontrolled growth. Those are the 3 words I'll typically use. Identical, uncontrolled growth. So it's a bit easier to think of as a piece of lung tissue or breast tissue, where you can think of it as growing as this little mass. But just like that grows as a mass, we can have the cells in the bone marrow grow out of control. the kind of double whammy of blood cancer is that these are the very cells that are meant to protect you. And I'm not trying to make any political statements here whatsoever. I've always used this analogy long before some of the challenges that have been made more aware to us over this last year. But, these are the police cells. These are the soldier cells. These are the cells that are there to protect us. And if those cells are the ones that now become cancerous and paradoxically attack us, it's really quite a dramatic situation. And that's the challenge of the immune system in multiple myeloma. So really, what is myeloma? Well, myeloma is a blood cancer that starts in the bone marrow with some specific cells that live in the bone marrow that are called your plasma cells. And these plasma cells are the cells that typically make antibodies. So we've been hearing so much about these antibodies. Someone gets unfortunately infected with COVID, their body reacts and makes an antibody. Or I give Kelly a tetanus shot in the arm. I'm not giving him tetanus. I'm telling his body, hey, Kelly, this is what the tetanus looks like. You prepare and be ready in case Kelly steps on a rusty nail and tetanus gets into his system. Well, where does that vaccination go? It goes to the plasma cells. And the plasma cells make antibodies or these special proteins that can help fight off tetanus when you get them. So, look, Nina and I are plasma cell doctors, so obviously we're a bit biased, but these are like the coolest cells in the body. They can react to vaccinations, to exposures, various things we get infected with. Your body is constantly trying to defend you by making these antibodies. And so plasma cells are great. The problem is when plasma cells become cancerous, now instead of making good antibodies, sometimes we call those polyclonal because they're different shapes and sizes, one's for measles, one's for mumps, one's for rubella, one's for tetanus, the flu, COVID. Hopefully we'll have a vaccination shortly for the SARS-CoV virus. But in myeloma, these same plasma cells now have become cancerous. And so remember, cancer is identical uncontrolled growth. We see more of them in the bone marrow. And now instead of making a good antibody, they make a bad antibody, sometimes called an M protein or monoclonal protein that can attack the body. And it's not a particularly common cancer. It is about 1% to 2% of all cancers. We know, as I've mentioned, that it's a disease that we classically make the diagnosis, but not always, in people over the age of 60. We have about 2% of patients that are under the age of 40. In fact, I just saw one of my patients this week in clinic who we did his bone marrow transplant when he was 25. We know that African Americans are at greater risk, that there is some association with obesity, and we'll talk in a moment about what comes before. I mentioned that with every measure we're getting, I was hoping to update the slide. It's almost ready to be updated, that we are seeing longer and longer survival with myeloma. I started back in the day. Nina was probably still in utero, but, in myeloma where, people sadly lived maybe 1 or 2 years with this disease. Well, the average patient now is living close to a decade with this. Now, there's a big variation. Some have more aggressive disease and some have less aggressive disease. But that's the happy part of the slide. These blue lines keep getting better. The sad part of the slide is still a gap between myeloma patients and the general population. We really haven't cured this disease yet. So I mentioned it's about 1% to 2% of all cancers. And these myeloma cells then, based on the type of bad antibody or monoclonal protein it makes, we can figure out what kind of myeloma they have. Unfortunately, this year we expect about 32 or 33,000 new cases and about 13,000 deaths from this. So these you can see these little funny-looking cells on the side. Those are your plasma cells that are making these antibodies. And the interesting thing about these antibodies, they look like they have this Y shape to them. It's kind of interesting because the top of the Y hooks on to the, let's say, tetanus, and the lower part triggers the immune system to destroy it. But you've got these little bits on the side. So that big antibody, the Y part, we call the heavy chain. The little ones are called the light chains. And in some myeloma patients, we can measure both. And in some myeloma patients, we only measure one or the other. So depending on your type of myeloma, you may have a light chain myeloma or a heavy chain myeloma. Now, I know this next slide can be a little intimidating, and I'm not trying to do it to scare anybody, but I just want to show you 3 words on this slide: elimination, equilibrium, and escape. Your immune system right now is working to protect you from cancer. It's trying to eliminate the tendency, just like a really good teacher. Nina is an outstanding lecturer, and she'll be giving a lecture, and she'll look and she'll see, hey, Kelly's looking out the window and he's not really listening to the lecture. And so she'll bring Kelly back into the conversation and things go well. It's kind of like your immune system that looks at some of your cells saying, hey, don't become cancerous now. You come back. Let's not do this. And so your immune system does that. Sometimes it doesn't work, though. Sometimes your immune system says, okay, fine, you can have a little bit of cancer, what's called equilibrium, where there's just a tiny bit. And myeloma is preceded by a condition called MGUS, where people have just a little smidge of cancer, not enough to really hurt anybody, but there's still that little schmutz of protein that we can measure, a little bit of myeloma in the system. And then unfortunately, when the immune system can't control it anymore, there's escape, or what we call full-blown myeloma. So when I try to make that more practical, we have these three categories of myeloma, what's called MGUS, where people do have a bit of the bad protein, but we don't treat them because, believe it or not, close to 5% of the population of the world has MGUS. I could argue that myeloma is the most common cancer on the planet. And we're, as you know, through the IMF, screening the whole country of Iceland to understand this better. Then there's the active myeloma at the other end, what we're going to be focusing our discussion today. And then in the middle, we have this thing called smoldering myeloma, where it seems that people are kind of evolving from MGUS to active myeloma. And we're happy to address some more of those in the questions as we go through the day this morning. So myeloma then is a cancer where you have these plasma cells that are growing in the bone marrow, but they cause damage. How do they cause damage? They cause damage through what we've historically called CRAB, or the acronym calcium elevation, renal or kidney complications, anemia or a low red blood cell count, remember the red wine, or your red wine stores are low, or bone disease, because it can unfortunately attack bone, as many as you know. Recently, however, we've added three more features to this, that if someone has more than 60% plasma cells in their bone marrow, if their light chain, what we call ratio, or involved over uninvolved, is over 100, or if we see these what we call focal lesions in the MRI of someone's marrow, then we say this is all part of myeloma. So my huge contribution to the myeloma community is I came up with the acronym SLIM-CRAB. I can drop the mic now and give up and retire. But we added to CRAB these three letters, SLIM, or three further features to define the disease. And so it's important to remember that the diagnosis can be challenging, because a patient doesn't come into a doctor's office saying, oh, doctor, I have a monoclonal protein and SLIM-CRAB features. No, that's not how you were diagnosed. Sometimes it's just fatigue. Sometimes it's bone, typically in the back pain, and often it can be anemia or the low red blood cell count. So that's why myeloma sometimes can be a different disease to catch. And we can see that these CRAB symptoms can be all over the body. So even though you think of it as a bone marrow condition, it really is a full body condition. The kidneys, as you see here, the bones, so many different things. So it can present just with infections, with weakness, with bone pain. And some people, as you see here at the bottom, don't even have specific symptoms. So based on the type of the plasma cell that you have affected, we can see different subtypes. I don't want to bore you too much with this, but most people have an IgG myeloma. Some have an IgA myeloma, and then there are those who have what we call light chain only, and we can discuss that more. Before I start talking about treatment, one of the things I think that is really important through these regional community workshops and patient and family seminars that we do through the IMF is to give you some ownership and to try and support you. The days of your doctor saying, here, take this, trust me, I'm your doctor, or just, listen to me, I'll teach you everything. Those days really are not here anymore. And so it's important that you learn your own labs. And in a short workshop like this, we can't go through every single one of these, but the short version is that you have blood tests that look at like the red, white, and rosé. We have what we call chemistry tests in the blood. And then you have the tests that specifically look at the markers of myeloma. And those three tests are the ones that are done almost every time you're seen in follow-up, so that we can see, just like a lung cancer doctor is going to measure on the x-ray how that lung cancer is shrinking with treatment, we measure in the blood how that bad protein is shrinking with each treatment. People always want to know about staging of disease, and it's pretty complicated in one way, but to be really simple in myeloma, there's only two stages: the stage that needs treatment and the stage that can just be watched. We do have this three-step staging system that no one expects you to memorize, but it's not like a lot of the solid tumors where, stage 1 and stage 4 is such a radically different disease. We think of really myeloma as much more together on this. So as we start to think a little bit about treatment, it's important that you be involved in this. Treatment decisions are not, I'm the myeloma doctor, you'll take it, you'll like it, and you'll ask for more. I mean, that's just not how we approach things. And I know Kimberly is going to cover some of that in her discussion as well. But when we look at a patient, we look at the patient as a person. As I always say, I don't treat myeloma, I treat people. And I have to approach that individual. What are their values? What are their goals? Their age, their other symptoms? Well, all those things factor into making a decision. So that when we choose a plan, we're not choosing it just based on some publication that says this is the top recommended treatment, especially now in myeloma where there is no cookbook. We have multiple different options. It's like saying, what are you going to cook for dinner? I love to cook for my 2 daughters. I have 2 beautiful teenage daughters. And as a single dad, I love to cook for them on a regular basis. And I don't just cook because, girls, you're going to eat this and you're going to like it. No, we think, okay, well, is it a warmer day in Arizona, which basically always is, but, so do we want, something lighter? What do we feel like eating today? I mean, I don't want to make it sound so simple, but when we make a decision about myeloma treatment, we engage the patient and their family and a whole series of factors that go into that. And part of it is because we have all these drugs, and I can't give you the drug 101 today, but we have major classes of drugs what are called immunomodulatory drugs, or IMiDs, the ones that end in mide, lenalidomide, pomalidomide, the proteasome inhibitors, the ones that end in MIB, bortezomib, carfilzomib, ixazomib, and then at the bottom, monoclonal antibodies, the ones that end in MAB, daratumumab, and recently added isatuximab, which is another new CD38 antibody, and then a whole of other drugs of which you all know the dexamethasone or the steroids that are really like the booster rockets that help any treatment we give in myeloma to enhance its activity a little bit more. And this is not a commercial for me by any means, but I do a lot of what I prefer to call expert opinions as opposed to second opinions. But my practice here in Scottsdale at Honor Health is seeing a lot of patients who are being cared for by someone else, but just to give further advice and further education to the patient. And these poor oncologists are treating 50 different tumors, and myeloma is pretty rare, and there's been so much change in myeloma, it's hard to keep up. And so you are entitled to that you can get an opportunity to speak to a myeloma expert. Maybe this is a tiny silver lining of COVID, that we have a greater opportunity now to be able to present, do many of these consults virtually as opposed to face-to-face. So my last geeky slide before I give you some general principles about treatment for my last 5 minutes is that this is a slide that looks crazy, but I want you to think it's simple. The purple dots are myeloma cells, and everything else is where the myeloma lives. And I want you to think about myeloma as not just being a disease where there's some bad tumor. This is a disease where the tumor has actually invaded your system, sadly, and is controlling parts of your system. And one of the great things you're specifically going to hear from Nina today is how we can turn the tables on that. We can literally use your own immune system against your own myeloma. That's what we call immunotherapy. And I show this slide to just show that you have all these parts of your immune system, things called T cells and natural killer cells and stromal cells, and we're engaging those to try and take down your tumor as opposed to just giving you the sort of traditional bald and barf chemotherapy. When we decide on first therapy in patients, we typically divide into 2 categories. Are you eligible for a transplant or ineligible? And we can get into more discussion of that if people want. But when we're treating people who are eligible, we typically give them this combination of drugs called VRD, or bortezomib, lenalidomide, dexamethasone, or Velcade, Revlimid, dexamethasone. That's partly based on a study that showed when we do that plus a transplant, we put people in remission longer than if we just give the VRD. And so this was a big study that was published and actually is just about to be updated in a couple of weeks at our big meeting. And so that's one of the reasons why we've typically been using this VRD strategy, although we also have the option sometimes to use what's called KRD, where instead of the Velcade or the bortezomib, we switch it out for a different drug called carfilzomib, which is another very potent drug that has a different, if you will, side effect profile that sometimes matches a patient better than the Velcade. And coming to a theater near you, I know it's hard to talk about theaters right now, but coming in the not so distant future is we're learning this great drug daratumumab, which is a monoclonal antibody So it's itself an antibody, like we were talking about earlier, that hooks onto the myeloma cell and triggers the immune system to destroy it. And we have several of those now, and most recently added a new one called isatuximab. We are likely going to be adding that to VRD. So we'll be giving 4 drugs instead of 3 in the not so distant future, because we saw when we added daratumumab to VRD that patients did well. And lastly, we may be looking at a situation where we, instead of just saying we're going to give you X number of cycles, we say we're going to give you as many cycles as gets your disease way down to where we can't even measure it, what we call minimal residual disease negative, where the floor is so clean I take out a wet Q-tip and I still can't find any dirt there, where we measure right down to the tiny amount. We can detect sometimes 1 in 10 million cells not having any myeloma present. And with these different strategies, and if you just look at the bottom right-hand corner here, we see huge percentage of patients that can get what we call a response or into remission, and a lot of them even to this MRD negative concept where we can't even measure disease. It's not really a cure, but it's the step towards a cure. And then secondly, if patients are not going to transplant, we also have lots of options. The first of which was a really important study led by my boss, Dr. Brian Dury, who's the chair of the IMF. So may it be clear that I am speaking well of the boss's study, and it really has revolutionized it, that actually it's the same treatment that we're using in transplant-eligible patients. So we give that VRD, but instead of giving it a transplant, we give it this combination together. Eventually we stop the Velcade and continue the Revlimid, and we've learned that it really improved not only time and remission, but actually improved overall survival. That people lived longer when they got this combination, which is one of the reasons why we do that. We also have another eligible combination. For time's sake, I'm just going to skip ahead to it, what's called from the Maya study, where instead of giving Velcade, Revlimid, and dexamethasone, we can give that daratumumab drug that I mentioned earlier with Revlimid and dexamethasone. And similarly, we saw when we give this combination, people do better than just getting Revlimid and dexamethasone. So the simple point here is that we're typically giving a 3-drug combination, usually Velcade, Revlimid, and dexamethasone, sometimes still carfilzomib, Revlimid, and dexamethasone, but now we have an increasing use of daratumumab, Revlimid, and dexamethasone. So I know these are a lot of words, and for some of you this is old hat, for some of you it's new, but I'm trying to present it in an overall a straightforward way. For time's sake, I won't talk more about that. So as I come to conclude here, there's more overlap than ever in the way we approach patients who are either eligible or not eligible for transplant. I sometimes feel it's important for me to give permission, as it were, to patients to say, you know what, you don't have to do transplant. Transplant is still a really important modality, but especially as we get older and have more other medical issues in our life, it's really important to make the right decision. Typically right now what we're doing is, out of these 3 big classes of drugs, the proteasome inhibitors, the immunomodulatory drugs, and the monoclonal antibodies, we're choosing 2 drugs. So kind of a mix and match. And as I mentioned before long, we may actually be giving all 3 with that DVRD regimen or something like that before too long. So to summarize, historically, we've had these 4 pillars of proteasome inhibitors, immunomodulatory drugs, monoclonal antibodies, and alkylators. That's the drug melphalan that we use with a transplant. But as Anita is going to show you in a few moments, it's amazing how we're adding all of these new drugs to this regimen. We have this new drug called selinexor, brand new drug, belantamab mafodotin, and we're going to even be adding more and more drugs as we go through before too long. So one way to look at it is this is typically how we're approaching myeloma up front. As I mentioned, with either a bortezomib, lenalidomide dex, or carfilzomib lendex, or even daratumumab lendex, and everybody stays on lenalidomide. And then at first relapse, if they've not seen it, we're typically giving daratumumab. But as we look to the future, and I'm now sort of teeing up what Nina is going to share with us after some Q&A, is that we're going to see a big change here in red with all these new fancy schmancy drugs and maybe even CAR T-cell therapy before too long. Another way to visualize this is to say, we see in this slide just a whole series of drugs that are typically piled on the far end, all these new drugs that we're going to be using in relapsed myeloma. And so it gives us cause to be excited. Look, I hate myeloma. We lost one of our patients this week who's been, she fought a tremendous fight with myeloma over almost a decade. And so we learned to hate this disease. And yet at the same time, we want to be optimistic that we have made a huge change over the last decade. And I suspect, despite the horrors of 2020, this may be one of the most exciting times we've ever had in myeloma as we look to new drugs in the future. So there again is my world map. And again, I just want to thank you for listening. I hope it's been helpful to you. I know it's a little rapid fire the way we're doing it today, but hopefully this can be of benefit to you as you go through. So I'm going to make sure that Nina and Kimberly join me as we come to review some of these questions that many of you have been submitting here. So thank you for submitting some questions, and I'm more than happy to try and start answering them now, unless Kelly has any other comments for us before we dive into the Q&A.
Yeah, I do. You know, that tetanus shot really hurt me when I was a kid. It was a big shot to me. But then, you get older and wiser, and you say you got that size of a quarter on there, and then you're living, you go, this is pretty good. But some of these shots that I've had taken over my life have been intense. And I've had a bone marrow biopsy, so I have a lot of empathy for people that have to do that. So I knew you were going to learn something more in this session than you've ever learned, and that's why I'm glad you joined us for 101 and the other therapies. But let's get into some more questions. I think we have about 9 or 10 of them coming up. And Joe, do you see those questions?
Absolutely. Absolutely, I do. So there's lots of different ways to approach these, and I'm just scanning them now. Wow, these are really informed and excellent questions. So I want to engage the others working with me here. So let me take this first one, and then Nina, I'm going to bring you to the one there afterwards. But one question was, are there any studies regarding myeloma incidence among Asian, Latin, and Native Americans? In fact, it's interesting this question is asked because I just did a very extensive literature review with help from one of my dear colleagues in North Carolina, Dr. Cesar Rodriguez, who's very interested in this. The short version is yes, not quite to the same extent as we've seen studied in the African-American population because it's not as common. The incidence of myeloma actually may be a little bit less in the Asian population. In the Latin population, we see that on average, for example, Hispanic patients have a younger age of diagnosis. We're learning a lot about this in our work in Latin America. In fact, yesterday I was in, virtually speaking, both Uruguay and Brazil, and we're very much understanding the nature of myeloma there and how it influences individuals that come to this country. We have a little less experience with Native Americans, although I know here in Arizona, where we have been doing a lot of work with the Navajo Nation and others, we actually believe that there is a higher incidence of myeloma than we had first thought. So these are things that, the whole notion of disparity in medicine has really grown in its research and its scope and its work over the last few years. And I hope by the time we do our regional community workshop next year, I can give you more specifics about what initiatives we're taking. But one of the sort of important themes here is that vulnerable populations are being affected more adversely by cancer and specifically by multiple myeloma. Nina, here in Arizona and you in San Francisco, you've seen a lot, unfortunately, of COVID. This is a great question that says, I'm a myeloma patient under maintenance therapy. Should I stay at home considering the COVID-19 world? How would you approach that, Dr. Shaw?
Yeah, I think everybody should be staying at home, no matter whether you have myeloma or not. And that's a hard thing for actually healthy people to understand. And in some ways, our myeloma patients are more educated and more aware of things that they have to do to be cautious around other people. And I know the holidays are coming. That's really difficult. So my general rule with my patients, and everybody's individual, but we talk about these things. Yes, stay at home. I think it's okay to go to the grocery store with a mask if you have to, but it's just everything's about statistics. So everything that you do is a statistical risk, and so you add that up, you go to a lot of places, your risk goes up. So minimize, I think, the number of times that you have to go to a place where you're interacting with other people. And I think that it makes holiday planning very difficult. And we've had these discussions. Every clinic says that, what am I going to do? Who am I going to see? And I've really just been suggesting that people just not gather, even my own family, which I also don't want to accept, but it's true.
So that's helpful, Nina, because you're giving us sort of the global perspective. I know that myeloma patients, and we've created quite a large registry now, or collaboration between myeloma doctors all over the world who have been involved with this. And a couple of principles to add to Nina's is that, the risk factors for COVID are many. And yes, there does appear to be a slightly higher risk for cancer patients. But in fact, one of the important things to notice is that one of the best ways we can protect our myeloma patients from COVID is to make sure their myeloma is treated the best way possible. So it is one thing to stay home. I totally support that. But it doesn't mean you stay home from getting the treatment that you might need, or
right.
seeing your healthcare team, be it virtually or in person, however it's set up for you. Because I think there is this fear that myeloma patients are such at risk, they just, they're hyper at risk, and so they can't do anything. And thankfully, we've actually not been seeing that. The number of myeloma patients infected are lower than we might have initially thought. So just to reassure you that one of the things that remains important is best control of your myeloma. That's going to be the best thing for your immune system, as I described earlier, to help protect you. So please go ahead.
Sorry. No, I just want to clarify. Yes, definitely go to your chemo infusions, et cetera. The hospital systems have made it much safer to get these. We've really thinned out who comes, how many people come, and a lot of people that can do video visits for an initial consultation, they do that. So there's less people there, but if you're getting chemo, please go to your visits because we want to control your myeloma. So completely agree with what Joe said.
So we have lots of great questions here, so I'll pick up the pace a little bit. What treatment do you recommend for a myeloma patient in remission but with persistent IgM deficiency? So there's the different IG or immunoglobulins, IgG, IgA, IgM are the three most common. That's probably something that has to be discussed a little bit more with your physician, because we typically do see the non-involved, like if someone's got IgG myeloma, that the IgA and the IgM might be a bit reduced just by the effect of treatment. And typically a lowish IgM is not a great concern. It's the IgG, if it's extremely low and people are having significant infections, we might supplement some of that IG with what we call IVIG or intravenous IG, or basically replace that immunoglobulin. But we don't have explicit treatment for IgM per se deficiency unless it's accompanied with infections. Another great question says, myeloma usually comes back and is resistant to initial drugs. Isn't it better to save daratumumab for relapse? And this is a very young patient asking this question. And this is a challenge. And, Kimberly and Nina, I'll get you to chime in if you wish after this, that we've always had this tension in myeloma. Do we use our best up front, or do we kind of save the best for last? I think we have really been leaning much more towards let's move things up front. Saving the best for last is great for a romantic song or movie, but really doesn't work in myeloma, because we've learned that those first remission is the longest remission. And although we know the disease will become resistant at some point, we don't want to be chasing our tail with the disease because it becomes more aggressive each time. So it doesn't mean we give absolutely every drug front line. We do have some strategies. Sometimes I call it the 1-2 punch, that your first line therapy and your second line therapy are really important. But we also want to make sure that we don't get into this trap where, unfortunately, we save things to the very end, and then by then the disease is so aggressive we can't control it. I don't know, Kimberly, has that been your kind of approach too in your center?
Yeah, it really has. And thank you for asking me, because it's a philosophical, sort of change in how we're treating myeloma patients. And I think that we have very convincing data to suggest, and I'm always impressed with how the studies are going, that, we're sort of comparing the 4 drug regimen to 3 drug regimens, just as drugs are being FDA approved. And so, we just get information all the time, and it's just so great to be part of this journey.
Thank you. And Nina, maybe I can ask you this question. Someone says, I've undergone a stem cell transplant and have stored cells. At what point would I receive a second transplant? So what's the role of second transplant?
Yeah, this is one of my favorite questions because, as you know, I'm a recovering transplanter, and I really think transplant's a great way to get rid of disease. What I would say is second transplants are good if you've had a very long time between your first and second transplant, and the time that your disease starts to grow. So, I mean, really like more than 3 years. You know, if you're on Revlimid for more than 3 years maintenance, and then your disease starts to grow, I think a second transplant is considered, because after that you can go on maybe some other kind of maintenance like pomalidomide. We don't know yet. The other place that I think second transplants are actually very useful are these sort of bridge to somewhere therapies. So, for example, that we've had some patients who are going to go to a CAR T clinical trial, and their blood counts were very low and their disease was rising, and this was a good way for us to give maybe a reduced dose of the melphalan, which is the chemo you get with the transplant, and then boost those cells up by giving an infusion of the stem cells, and then their counts were much better, able to tolerate other therapies subsequently. So I think that's the other role for a second transplant, but it's definitely something to ask, and that's one of the reasons I always collect for our younger patients.
That's a great answer. You know, in a disease that we're not curing, we want as many options as possible. I got a couple of rapid fire questions here that I'll answer. What does consolidation really mean? Consolidation is a word we use in cancer that when you think of what we call induction, that's meant to induce a remission. That's where you get the biggest drop in the measurement of the disease. Let's say someone's M spike. Consolidation is usually a shorter treatment that's intense, that's designed to get it down that last little bit. So it's all about, if you will, depth of response, that we like transplant as a consolidation, or sometimes we may give a little bit extra chemo after transplant to so-called consolidate it. And then lastly, maintenance therapy is the idea of less intense treatment that's not really getting you any deeper, but maintaining you at that depth. So it's more of a duration concept. So that's why consolidation tends to be more intense things. Maintenance tends to be more gentle. It's not a perfect example, but you remember those days where we used to actually write letters and put stamps on envelopes? You know, it's like the stamp, like the induction is bringing the stamp all the way down to the envelope. The consolidation is that extra little push you give to it to make sure it's stuck down. The next question is, recommendations have been made that myeloma patients should have a second flu shot. So there has been some work about this sort of higher dosed flu shot, and right now, honestly, there isn't consensus in the myeloma community. We're still exploring it. The data is still relatively new. The way I look at it is that all myeloma patients should at least get the flu shot. There seems to be some benefit in getting that booster, that second one. Sometimes insurance doesn't cover it. There's some challenges with it. I've asked a lot of myeloma doctors, and I don't know, Kimberly, if you have a comment as to what you do at your center. Right now, it's not formally recommended, but I don't have a problem if one of my patients wants to get the second step of the 2-stage flu shot.
No, we do not recommend it, but there are, primary care physicians, for example, that have recommended it, and we certainly don't get in the way of that, but that isn't our recommendation.
Nina, don't collapse at this question. As new drugs become popular, will transplant be discontinued?
Oh my God.
Don't hit me.
I think there's a lot that we could talk about all day with transplant. It's a good way to, just as Joe you were just saying, getting that extra push on the envelope to stamp it out. I call transplant the Brillo pad of myeloma therapy, because it really digs out that stuff that you can't see on the dirty pot. So it's a good way to get rid of that. We know in study after study that transplant has improved the progression-free survival, so how long you live without having the myeloma come back. That may or may not hold up in the most upcoming data. We don't have that data yet. That's going to be maturing in the next 1 to 2 years from the most recent study. We don't know. But so far, it seems that transplant gives you help. I think if nothing else, it allows people to limit their number of cycles of chemotherapy up front, get the transplant, and then move on to what I think is a very outpatient life-friendly, although it has its toxicities, regimen, which is the Revlimid maintenance, or whatever maintenance you choose. And so I kind of see it as trying to get the patient back to his or her life, which is one of the reasons I really do like transplants. But I think what's going to happen is that we'll have other therapies that will be a good tag on to transplant. Like I think CAR T could potentially be a good post-transplant therapy for any minimal residual disease or something like that, as we get smarter about our clinical trial design.
Perfect. Kelly, with your permission, can we spend just a few more minutes doing questions? It'll put us only 5 minutes behind, but there's such great questions here.
I agree with that. It's amazing. You guys that are attending this are really asking some great questions. Please take it away, Dr. Joe.
Excellent. So I'll answer this next one briefly. So question is, if I had a transplant 14 years ago, so congratulations that you've done so well with your myeloma, and now I'm smoldering with a bone marrow biopsy 1 year ago showing 30% myeloma, how often should I have a bone marrow biopsy? My last PET scan was clear. Obviously, it's hard for us in meetings like this to give very precise advice because we need to know the whole context. But the short version is that we're not typically just following people with bone marrows unless they have no other way of measuring the disease. We'll typically follow people with blood tests for that M spike or for their light chain, sometimes with PET scans if they've had disease that is outside the marrow, as we sometimes call extramedullary disease. But we wouldn't typically just say, oh, get a bone marrow every year. 30% is not a percentage that makes me think, like as I showed you with Slim Cram, that at 60% that we may have to do something right away. But I would not formally plan to do a bone marrow unless there was a change in those blood parameters. Lots of transplant questions here, Nina. To transplant or not, over 70, good health, good response to VRD, but not MRD negative. And I just want to address this real quick, and then Nina, you can chime in. I think there's a bit of a false thinking when people say, oh, I have to get to MRD negativity before transplant. Of course, people who get a deep response do well in the long term. That's just a natural cancer phenomenon. Responders respond. I know that's the deepest statement I'm going to make today, but I think we also have to be careful. We can let the Brillo pad do some of that scrubbing, as Nina just said. So I did a consult recently where someone said, well, I can't go to transplant because I'm not MRD negative. I think that's not exactly correct thinking. We do want to get some response from that induction, but we still can have a benefit from transplant. And we've even seen benefit to transplant, even those people who have achieved MRD negativity. Do you agree, Nina?
Yeah, definitely. I just want to say MRD negativity for data has most commonly been studied after transplant before maintenance therapy. So the utility of the MRD data before transplant is not as robust. So I try not to get my patients too upset about that at all. Second, we don't know whether MRD is a reflection of the patient, of how you're doing, or a goal to achieve. We don't know that yet. And that's why there are clinical trials being designed with MRD as a decision point so that we can decide, so we can figure out, is the goal to get to MRD negativity, or is this some information that we can then use only for using, not for a goal, to tell our patients, okay, you're MRD negative or positive, so we predict your progression-free survival, time without disease is going to be X or Y. So I wouldn't worry at all about having MRD positivity before the transplant. Like Joe said, the transplant may make this even better, but just focusing on the International Myeloma Working Group responses for now, and moving on with the treatment that's recommended.
Nice commercial for the IMWG. Well done, Nina. Scoring some points. Good. The International Myeloma Working Group, we're the 200 myeloma geeks across the planet that really focus in myeloma, and the IMF has a privilege of hosting that group. Kimberly, I think I'm going to ask you this question. This is a patient who says that she has IgA lambda light chain myeloma. She went through aggressive chemo and went into remission, but now it looks like her numbers are climbing. She got what appears to be 20% plasma cells. Do you recommend starting chemo, or do you just wait and watch? So I know this is kind of a philosophical question in some way, but when do you wait? Do you wait for people to start breaking bones and having kidney issues, or do you intervene quickly? What's the philosophy to relapse? And again, this is a bit of a preamble to what Nina will share with us in a minute.
Yeah, I think we need to hear Nina speak before I answer. But anyways, certainly you want to work this up. You want to, see if you can get a PET CT. You want to do a bone marrow. IgA is a little worrisome, as we know. And you have to look at the whole clinical picture. What's the renal status looking like? So you have to look at all that CRAB criteria and weigh in and, really make a decision, a team, approach with the decision with lots of data.
Absolutely. And that's absolutely, I think, the way we would all approach it. I think there's been a little bit of a shift in the thinking in myeloma of late of, I use the analogy because I'm a runner. I love running here in the desert. I try to do that every day. And if I'm running towards a cliff, hopefully Nina is going to see that I'm in trouble and pull me away before I fall over. But if the cliff is miles and miles away and I'm running slowly, which I probably would be, then it's not as much of a risk. And so when we look at patients and we see that their disease is coming back, we want to assess that tempo. We don't want to wait too long. We don't want to wait until you're in real trouble, but sometimes we can wait and watch. a little while. We've got about 1 more minute, so we'll try and get a couple of these questions answered, and we still have a second Q&A later. We may be able to carry over some of them. One question is really about CD38 drugs, saying that someone is currently on daratumumab, Rev-Dex, and at some point the disease will break through daratumumab. Can they use another CD38 drug later, like daratumumab again, or maybe isatuximab? This is one of the most important questions in myeloma right now that we really formally don't have answered. A couple of things we know is that going from one CD38 immediately to another when you're breaking through the first one is probably not ideal. It appears that if we stop a CD38, give people a so-called CD38 drug holiday for 3 to 9 or maybe an average of 6 months, that there may be more CD38 present on the cells. If you're not familiar with it, myeloma cells have this little thing that stick out of them called CD38, and this is a drug that hooks onto that to help destroy the cell, that it may be valuable to potentially repeat that or bring in another one like isatuximab. But it's still a little bit early to formally answer that question. So I think because it's just about at 11 o'clock here Central or Mountain, I think we'll take just one last question, which Nina, what advances are being made with some of the high-risk patients? So where were we making some progress with high-risk myeloma?
Yeah, that's a great question because that is probably, in my mind, one of the biggest unmet needs in myeloma. And so we have really been trying as myeloma researchers to press both drug companies and societies to look at this patient population. And one of the things that we're trying to do is see if maybe immunotherapy like CAR T-cell therapy can actually be used earlier for these high-risk patients, because we know that the therapies have done well in the later lines. Maybe we could take advantage of that, use it in the earlier lines for high-risk patients and give them a longer plateau on that curve, if you will. So that's one of the things we're interested in. But I would encourage anybody with high-risk myeloma, please try to look for a clinical trial if you can, because there are clinical trials around, and we need patients like you to help us understand that, and hopefully that you could benefit as well.
Great. So there's so many more great questions, and actually I think I'll try and get to them at the next Q&A, Kelly. There's some really good questions here about plasmacytomas and so on, but for time's sake, why don't we move on here to take a really quick stand-up stretch break. This is, I think, really important. Don't you think, Kelly?
Yeah, you gently, everyone, just take your time on it. These are some yoga position that Kelly Sidorowicz, who's on our support group director, has put together. But we do this just for a few minutes at every meeting because you forget. Two things that people forget to do is they forget to stretch and they forget to breathe. Both are important. So the next slide we're going on to, after this stretch, we'll do one more thing here. Giving Tuesday's coming up, and it will be 12/1, and we'd like you to participate in any way, or just text us, and all those kind of things help. You can take that right off the screen. We'll leave that there for about a minute more. And I told you guys that we were going to have some great questions, some great talks, and was I lying or not? This has been a great one so far. I can't say enough about these two doctors. I've been around for a while, and they've been incredibly helpful to me so I could spread the word to other patients. So I'm very grateful to these doctors. Nina Shaw and Dr. Joe McHale, stand-up people, like to answer your questions. They're straight about this stuff. So if you're getting confusing information out there, let's get you unconfused. That's what this is about. So without further ado, how do you like I keep putting the regional community workshop in there so you guys remember where you are? I'd like to introduce Dr. Nina Shaw, who is going to go into relapse therapy and emerging therapies in clinical trials. Definitely get your notepad out. Definitely get a sharp pencil. This is some amazing items in the slide deck that you're definitely going to learn something. Nina, are you there?
I'm here. Can you hear me?
I can hear you perfectly. Take it away.
Okay, perfect. So thanks so much for coming to join me on a Saturday. I know you could be probably anywhere here with us, and I just want to say that it's the most important thing that you can do is just getting more information. Even for me as a physician, that's the most important thing I can do. So I'm just really thankful for your time today, and we're going to try to go through a lot of important data, and I know it's a lot, but hopefully we can detail some of that during the question session. We'll be talking about relapsed and refractory multiple myeloma in this session. So just as a little graphic here, you can see that relapsed myeloma, it kind of has its way of accelerating. And the point of this slide is to say that each time there's a relapse, and I think many of you may know this, it gets a little bit harder to treat the myeloma, a little bit harder to get the response, and maybe that response lasts for a shorter amount of time. And we're really trying to move this to be a curve that's to the left, where you could have a longer time from each one of these therapies and maybe have more deeper responses. As you can see, we're going to talk about a bunch of therapies, but I really want to point out on the right how myeloma therapy has improved, which is really a testament to all of you for participating in various clinical trials. So as you can see here, there have been a lot of randomized studies done, and what they have shown is that when you combine therapies with a Revlimid or lenalidomide and dexamethasone backbone, you can generally get an improvement. I don't want to make too much of the numbers on this slide. What I want to point out is that in every case where a drug has been added, so carfilzomib, Revlimid, dexamethasone versus Revdex, evotuzumab, Revdex versus Revdex, daratumumab or Darzalex, Revdex versus Revdex, and ixazomib, IRD versus Revdex. In every single one of these, we've had an improvement in the progression-free survival. And that word progression-free survival means how long are the patients on this therapy without having their disease grow back. And so a longer PFS is better. And in every single one of those, we've been able to improve such that the risk, which we always like to show is less than 1, it is actually less than 1 in each of these trials, as you can see in the red box. What does this mean? It means that we know that we're getting better at treating relapsed myeloma disease. Here you can see now, if we use bortezomib dexamethasone as a backbone, again, you can see pomalidomide Velcade dex versus Velcade dex, daratumumab Velcade dex versus Velcade dex. There is a double versus double combination here, carfilzomib, one of the earlier trials, KD versus Velcade dex, and then another trial with panobinostat, as well as evotuzumab. Again, all of these are showing us that 3 drugs can actually have an improvement over 2. And what they do is they kind of add to the sort of paint color palette that you have of what can we possibly use when people have relapsed myeloma. And I think I've always said that relapsed myeloma is where myeloma becomes less of a science and more of an art, because you have to choose the therapy that's the most optimal for every patient. So what can we say? Triplets are superior to doublets, and I truly believe this. I feel that if somebody has relapsed disease and has a pretty good performance status, that patient should be offered 3 drugs, so dexamethasone, something, and something else, versus just dexamethasone and something. And we've shown that trial after trial that 3 is better than 2. And actually now the FDA doesn't even allow us to compare the control arm to 2 anymore, and that's just fallen by the wayside because it's not fair to randomize patients to doublets anymore. Okay, so a lot of you will be patients who have gotten maybe Velcade, Revlimid dex, we call BRD, then a transplant, and then lenalidomide or Revlimid maintenance therapy, and you're on maintenance therapy. And then what do you do if the numbers start rising, right? So we call people lenalidomide exposed and lenalidomide refractory patients. And those are difficult. They're semantic things. And for the purposes of this, we're just going to treat them as the same. And so for people that have had Revlimid and their numbers are going up on that, there are several options that I just want to highlight here. The first is a combination called daratumumab, pomalidomide, dexamethasone. This data was presented a few years ago, and actually, in a way, the randomized trial is still maturing, but it took off. It just ran away. This combination was initially explored by my colleague, Dr. Ajay Chari. This is daratumumab, pomalidomide, dex, or Darzalex. Pomalyst dex, as many of you may know it, and this was looked at in multiple myeloma patients who had relapsed. And at the time, a 60% overall response rate in this patient population was seen as a major, major benefit. And for this, the FDA kind of fast-tracked the approval of this regimen for people with relapsed myeloma. Initially, it was used in people who had 2 lines, so maybe Revlimid, after VRD transplant, Revlimid maintenance, and then another line. Then you would use this. But I bet most of you have seen that people have been using this just even in the second line, so the first time there's any progression after maintenance therapy. And that this has really become something that's easier to do now that we have something called subcutaneous daratumumab. It's also known as FastPro. And it's just a different way to give the daratumumab. Instead of giving an IV injection, it's actually just an injection in the belly. And after the first few doses, you really don't have to spend much time in the oncologist's office at all. And so this is something that turns out to be a little bit convenient for these patients. Another kid on the block, if you will, is isatuximab. So daratumumab is an antibody, as Joe was explaining, sort of those Y-shaped proteins against the CD38, and isatuximab is a different kind of antibody, but it also targets CD38. It's a Coke-Pepsi situation, kind of similar but different, if you will. And this therapy has been being developed sort of in parallel with daratumumab, but I would say this is sort of the new kid on the block. Just from a development standpoint, it's just taken a little bit more time. So you can see that isatuximab binds to the CD38, which is the protein that, as Joe pointed out, sort of sticks out like a lollipop on the myeloma cells. So this drug was recently approved in relapsed myeloma, and the reason it was approved was because of this study design, very similar to what we already talked about, that 3 drugs were compared to 2. So this is back when you could do the trial like that. Pomalidomide dex was compared with pomalidomide dex, which was a known potentially active regimen in relapsed myeloma, and it was continued until patients either progressed or couldn't tolerate it anymore. So these patients were randomized to get either isapom dex or PomDex. So let's look at what happened. These are the progression-free survival curves. And I just want to sort of orient you. When you see these curves like that, in general, the one that's on the top is better. Because why? That means people who are in this group live longer without their disease coming back. Every one of these points is somebody whose disease has come back. And so people live longer when they get the 3 drugs, the 11.53 months without the disease versus just the 2 drugs, which is the 6.47 months. So actually, as you can see here, there was almost, I wouldn't say a doubling, but close to that, a very significant increase in the amount of time people were able to stay stable without the disease going up. And this ultimately led to the approval of isatuximab from this quote-unquote ICARIA clinical trial. And this is good because we want to have options for our patients. I think one of the questions we have about this is how do we compare this to the more widely known daratumumab? And that question has not really been answered yet, but it does give you an option to combine with pomalidomide just as daratumumab. But of course, what if you went all out, had like a crazy party with all the new drugs that you could possibly have that are approved, and looking at anti-CD38 antibodies and carfilzomib? Many of you have had carfilzomib. It's sort of like the more effective proteasome inhibitor than Velcade. I call it the Mark Wahlberg versus the Donnie Wahlberg, sort of the newer, more talented version of the Wahlberg brothers. But in any case, there have been some trials that have looked at this, and most recently, this trial was published and led to an FDA approval. This is the CANDOR study, and in this study, patients with relapsed myeloma were randomized to receive either carfilzomib, dexamethasone, and daratumumab. So carfilzomib and daratumumab were sort of the more active part of this regimen versus carfilzomib and dexamethasone. Again, a triple versus double. So you already know what's going to happen. But the point is, this is a new combination, right? We've always thought of carfilzomib as being sort of this very flashy proteasome inhibitor that's very effective, even in patients who have had Velcade. And of course, daratumumab, has flashed on the scene with being very effective as an antibody therapy. So everybody was very excited to see if you combine these 3 drugs, dex, carfilzomib, and daratumumab, would you do better than just a standard carfilzomib and dexamethasone? And as you would imagine, again, looking at these lines, the blue line versus the yellow line, the triplet group did in fact have improved progression-free survival. And in fact, the median, sort of when 50% of people have progressed or not, hasn't even been reached yet in the data that we have so far, whereas it was reached around 16 months in the doublet group. And this ultimately led to FDA approval for this regimen in patients with relapsed myeloma. And you may be hearing about this as an option if any of your physicians are considering therapy after you've progressed on whatever you're taking now. Not to be outdone, isatuximab also, isatuximab being the other kind of CD38 antibody, so again, the second kid on the block, this was a study of combining isatuximab with carfilzomib and dexamethasone versus carfilzomib and dexamethasone. This is the IKEMA study, which forever I kept calling IKEA, but it's actually IKEMA. And this is very similar to the study you just saw, using an anti-CD38 antibody with carfilzomib and dexamethasone versus just the carfilzomib and dexamethasone. Again, patients were randomized to receive the 3 versus 2 drugs. Again, we all know 3 is generally better than 2. And again, patients were observed until their disease came back. And again, you can see here in the blue versus the red line, or the sort of hot pink line, that the ISA-CAR-DEX was much better than the carfilzomib and dexamethasone. And although this is not quote-unquote FDA approved yet, it is now seen as an option and a competitor to the combination of daratumumab, carfilzomib, and dexamethasone. I know I've thrown out a lot of drug names right now just in the past 5 minutes, but the point of it is to say that there are options out there, and the combinations of these options and what's right for you is an individualized decision, that something that you want to talk to your physician about, and also taking into consideration your schedule, where you live, how far you can drive, other what we call comorbidities or health problems that you may have. All of these things come into play to making a personalized decision for you. So not to be outdone, just want to recap. 3 drugs are better than 2. And if you have a lenalidomide refractory, meaning that you've progressed, even though you're on Revlimid, for many of you maintenance therapy, you have at least 4 options here, in my mind, that take into consideration new drugs that you will not have seen before. So the 4 that we talked about: Dara-Pom-Dex, Isa-Pom-Dex, Dara-Carfilzomib-Dex, and Isa-Carfilzomib-Dex. So there are definitely options for relapsed myeloma. I think the question happens is what happens with multiply relapsed myeloma. And I think there's no myeloma patient that I have met who hasn't heard of what's going on with myeloma. This is what I call the it girls of myeloma therapy, which are the BCMA targeting therapies. And I'll talk about BCMA in a minute, but this has just made such a splash because it turns out that this drug, or this target BCMA, actually has a lot of efficacy or as a target for myeloma. So what is BCMA? I don't want to get too much into the science of it, but to make a very long story short, it is another protein that sits on top of the myeloma cell, just like a lollipop, and it's a target. And it's very specific for myeloma cells, meaning although the function of it, we don't really know, it probably helps myeloma cells to live. It's not that the function is important, it's that it is specifically expressed on these myeloma cells, so that if you target it, you're likely to kill the myeloma cells, but not kill other important cells in your body. So that helps it to be an effective target while still being safe. What can we say about BCMA targeting? I think everybody has heard about CAR T cells, and I just want to really point out what they are. The CAR T cells, as you can see in this diagram, combine the best of both worlds. So the T cell, which is this orange cell on the right-hand side, it's engineered to express this thing called a chimeric antigen receptor, or CAR. And what that does is that on the outside of the cell, it is very specific. It only binds to a specific protein, in this case, the BCMA that we talked about. But on the inside, it tells the T cell, go kill it, go kill it. Usually these T cells only kill things in a very specific manner that has nothing to do with the cell surface. Like the BCMA would be very different. It would be a different way that these proteins are presented. But this T cell is now re-engineered to only kill these BCMA showing cells, which happen to be the myeloma cells. And because this was already getting so much hype, the KARMA study was presented this past year. And this was actually a pretty large study of 128 patients who got this therapy after having ridiculous amounts of myeloma. And these people had a median prior lines of therapy of 6. And just to explain that to you, that means if Revlimid, Velcade, dexamethasone, then transplant, and then Revlimid, that's considered one line of therapy. These people had 6 different lines of therapy before they got on this trial. They were just very heavily pretreated. So what happened to them? As you can see, the right hand, the most right-hand bar here, shows a response rate of 73%, meaning 73% of patients did respond to this therapy. But if you look on the third bar, actually 82% of patients who got the highest dose of cells responded. 82%, which is crazy. I mean, this is really hard data to get in this very, very heavily pretreated population. The median progression-free survival was, for all doses, was around 8.8 months. But I actually think the more relevant data for this particular study is that what we see on the left, on the top bar, that if you see that dark blue line on the top, for people who got the 450 million dose, and that's actually the dose that's being asked at FDA, can we get approval for this? Those people had a median progression-free survival of 12 months or a year. Why am I pointing that out? I'm pointing that out because people who got this therapy, and no other therapy. They've just got this one therapy. They were able to just stay steady and not get any other therapy for a year without their disease coming back. And this is people who are so heavily pretreated. And that's what I think is the promise of the CAR T-cell, is actually getting one therapy and then not having to see your oncologist every week. For me, that's good. Although I love my patients, I'm sure they don't want to have to come to my infusion center every week. There's another CAR T-cell therapy from Janssen. Also very exciting data. Their data is earlier, so we don't have those curves that show how long people are living without disease, but this data had 100% overall response rate. Every single patient of the 29 that they first presented in their initial data, 100% of them responded. Their disease went down. So at our upcoming ASH meeting, our Society of Hematology meeting that's going to be in December, we're going to get updated data on this. I'm looking forward because there's over 100 patients that have been enrolled in the final study, the one that's ultimately going to hopefully get this CAR T product approved at the FDA. And I'd love to see what the long-term data is. So you can see here, I just want to actually really point out on the right-hand side, the response rates anywhere between 70 to 100% for these CAR T cells, really unprecedented. If you think about how sick these patients were, I didn't go into the safety a lot, but as someone who's treated over 60 patients with CAR T cells, I can tell you it's very well tolerated, and actually something I think our older patients can tolerate even better than transplant. And I love transplant, but I also think that this is very well tolerated. And I put my older patients on these trials all the time. Wanted to really talk about two more things. This is the bispecific T cell engagers. I know that many of you have heard of the word BiTE, and that's what it stands for, bispecific T cell engager. What is this? It's a protein. So bottom there, you can see there's a little protein, the BiTE. It's a green and yellow protein. On the one hand, it binds the tumor cell that's on the right-hand side. It has that green binding to the tumor cell, but the protein on the other hand binds your own T cells. It binds a molecule on the T cells. So what it does is it brings them together. I call this the e-harmony of immunotherapy, although, of course, it is Diwali today, so I have to give a shout-out to, let's see if it's animating here. Seema from Mumbai, the Indian matchmaker, which I should just point out that I did myself dress up as for Halloween, got a lot of remarks on that. So it is the matchmaker therapy. And what's so exciting about this is an outpatient, potentially outpatient-friendly regimen. The first couple of doses may have to be given inpatient, but some of these doses are given weekly, and then for some of these drugs even stretch out to every month. And that's what this data showed. The first data we had for a longer acting bispecific therapy, you can see here there was almost 90% response rate. Again, these patients had a lot of therapies, 5 different lines of treatment. This is a drug that's being developed by Celgene and BMS. And there's another drug being developed by Janssen, very similar idea, a bispecific therapy. Again, something that you can get without having your T cells taken out of you and engineered. You can see here that these patients actually had 67% overall response rate at their higher doses. Again, very heavily pre-treated patients. These are so early in their development. They're such early trials. These are all what we call phase 1 trials, where we're trying to figure out if the drugs are safe or not. You often never find efficacy signals like this in phase 1 data. And so we're very excited for these things to eventually grow and become part of our tools with FDA approval. Now, one thing that has recently been FDA approved is something called belantamab mafodotin. This is what we call an antibody-drug conjugate. So kind of similar, but a little bit different idea. It uses this BCMA protein as a target, and there's a little molecule you can see here on the top, the ADC, and that molecule binds to the BCMA protein. But on the other end of it, it has a weapon, and it was called an MMAF, and this weapon is deployed specifically to the myeloma cell once it binds. So this is immunotherapy in the sense that it's using an antibody to bind to the cell, but the real business is going on because it's deploying this warhead, this drug molecule, and that allows for directed toxicity to the myeloma cell. So this was developed this was studied in what we call the DREAM2 study, and just in the red box, you can see, just like the trials I showed you before, people had 7 prior lines of treatment, so very heavily pretreated patients. They had seen all the drugs that you can imagine, and they went on this trial. And as you can see from the data here, that patients had 30% response rate. So it's not the 80 and 90% data I was showing you before, but 30% is actually sort of the level that we expect in this patient population. And because of that, this drug was FDA approved. For people who did respond, their responses lasted around 11 months. And I think this is important because it's the kind of drug where your doctor may suggest it to you and you may try it. And if you don't respond, okay, you don't respond. But if you do respond, you have a chance of maybe having a response for almost a year. And so I think it's a drug worth trying. It's important to know that if you do consider using this drug, there are some interesting side effects. There's something called keratopathy, with an ocular side effect, and this has to be managed by observation by an eye doctor. So you have to be seen either by an optometrist or an ophthalmologist if you're on this medication in order to make sure that you're maintaining safety. And that's something we could talk about a little bit more in the discussion. So I just wanted to close to tell you a little bit about how we're thinking about these therapies. There's so many, and if you're a myeloma doctor, it's just so exciting to be able to think that you might be able to bring new therapies to your patients. But if you're a patient, it's even more exciting or hopeful that there might be more ideas out there, and people are even working to improve the things that you saw today. People are in the lab at my institution, TGen, all these places working to make these therapies better. If you compare them, there are good things and bad things about each of them. Some of them are one-time only. Some of them require hospitalization. Some of them are ready for outpatient. But there are different myeloma patients and different drugs to go around. So with that, I want to just say thank you for having me. I think there's no one way to treat relapsed myeloma. It's like a Coke machine with all the various different options. There's new agents moving forward, and I think the BCMA agents are really going to change how we treat myeloma. With that, just want to say thank you, and I hope we can all see each other in person soon.
Wow. I told everyone to get their notepads together. Now, not only that, I want a Coca-Cola after the meeting, so thanks for showing me the machine. That was fantastic. All right, we got some questions, a little bit of time. I see a few of you sending them out.
Yeah,
Gosh, that was fantastic.
What a great lecture, Nina. Thank you so much. I think we're not just trying to dazzle the crowd with the number of drugs we use, but the number of analogies you and I have been using, especially on Diwali. So I hope you get a chance to celebrate afterwards. So I think what I'll do is just quickly address a few of the questions, and then there's some new ones for you, Nina. Some of the previous questions, someone was asking how accurate a bone marrow biopsy can be because someone had a negative bone marrow but seemed to have lesions elsewhere. I guess one way to explain this is that myeloma is a bit of a strange disease. It typically lives in the bone marrow. That's where plasma cells generally live. And that's where, in the overwhelming majority, well over 95% of patients, we can find the disease. But sometimes it's a bit strange. Sometimes it ignores the headquarters. And because these are the kinds of cells that can actually pass through organs, plasma cells can go and kind of nest, if you will, elsewhere. There is this phenomenon called solitary plasmacytoma, where someone just has a single collection of myeloma cells. We're actually learning that that's extremely rare. Now that we have better techniques to detect them, we usually find that actually there are multiple nests, and we may as well treat them like myeloma. So again, as someone commented, we can't give you specific therapy recommendations here. We're trying to be general, but this is something that I would recommend you speak to someone who has expertise in the area to be able to really address it with you. Someone's asking, saying they just got over COVID, that they had to stop their treatment, and now it appears that they're getting back onto the treatment. Nina, I mean, are you doing anything differently? How long are you waiting till someone has fully recovered to restart treatment, and are you making changes after?
Yeah, so there are some rules actually at our own hospital that they can't come to a certain time and they have to have COVID negative. So that sometimes changes when they can start treatment itself. I've been generally waiting a few weeks depending on how severe their symptoms were. And that, again, is a little bit, there's different severities of COVID. Just positivity with asymptomatic disease is not the same thing as having been intubated or, very, very sick in the hospital. So definitely something that's an individualized decision.
Great. And then the last question from the previous session was, are we going to be able to replace bone marrow testing with blood testing? And that's a whole lecture in of itself that I love to give. And Dr. Dury and our team, through what's called the Black Swan Research Initiative, our objective of curing myeloma, it's a big part of what we're doing. The short version is it's not ready for prime time yet. but we are developing more sophisticated techniques that after we've done that original bone marrow, we may be able to follow people's disease and various features in the blood. So that you don't have to, Kelly talked about getting a bone marrow biopsy. We know it's not the most comfortable thing in the world. So we hopefully will be able to avoid that in the future. So we've got a few relapse questions now for you, Nina, and we have a good, at least another 5 minutes or so. This is great. We're right on time. How long is treatment with Dara-Pom-Dex in relapse disease?
Yeah, I think any relapse regimen, I've always called myeloma marathon disease because that's what it is. You end up staying on treatment for as long as it's tolerated or until patients progress. But it does sometimes mean that we modify the doses. For example, like we might say, okay, we'll decrease the pomalidomide or stop the dexamethasone, but you'll still go on the Dara. So indefinite, but with modifications.
That's great. Nina, are you familiar with any treatments that can actually enhance CD38 expression on myeloma cells?
That's a great question because we're just launching a clinical trial using a drug called azacitidine. This is a clinical trial to try to increase the amount of CD38 that we're going to see on the cell. But so far, we don't know for sure if this is true. We're going to have to see it by clinical trial. So far, we don't know.
Yeah, it's great. And that's why I asked you the question, because I know that you were doing that study. There's actually been some other earlier stage studies that are similarly looking at greater expression of BCMA. So it's just opened a whole new avenue of what we're doing in myeloma, which is to, if you will, sensitize the disease to treatment, being able to make a treatment more effective. I mean, if I really had to summarize what we've been doing from, the early days of myeloma to now, we've really gone to a direction where we're being more precise with less of the so-called friendly fire to the patient. And that's really what we ultimately want to achieve. That's what's happening in cancer therapy in general. So I really think some of these therapies will show a lot of promise. Do you think, someone asks here, Nina, do we think that the bispecific therapies that you're discussing, do you think this is the potential cure for myeloma?
I hesitate to use the word cure because we've never gotten there, and I am an Indian mom, so a little pessimistic. But I think that this could give us a long duration of therapy that's outpatient friendly. That's what I really am hopeful for. I want myeloma patients to get back to life, and many of my patients who have gotten this actually have gotten back to life. So I'm very hopeful for that.
That's great. And then we've kind of addressed the transplant or not option, so I'll skip that question for now. But one other question that's interesting here, Nina, is how we think a little bit about relapse and defining progression. Like, do you stick to the very strict 25% criteria of a rise in M spike on 2 occasions? Do you want to just talk a little bit about the way, I know that, Kimberly mentioned earlier the sort of the strategy that we take, that we look at all factors and areas, but do you want to make any more comments about how we sort of define the progression?
Yeah, I generally use the IMWG criteria, actually very religiously. The reason I do that is because all of the clinical trials that have shown benefit used that criteria. So I know that that's a good baseline for me to work with. If a patient hits that 25%, or usually that's around 0.5 in the M spike, or 100 or more in the differences between their light chains, then I start having the conversation, hey, we should get a bone marrow, we should get a PET, because that tells me how quickly or not quickly we need to start changing or doing something else with therapy. And that can give you so many different results. It can show you different DNA that you may have now that you didn't have before in your myeloma cells, and it can show you that there's something in the bones that wasn't there before. If all of that is negative, then the patient we talk about what options might be there to either watch for a little bit longer, maybe they have a trip planned or whatever, something, an event, or go on with a therapy that might be a little bit less aggressive.
Really helpful. So Kimberly, I may get you to chime in on this one because, I know at your center, you guys use so many different therapies and options. Where do you see elotuzumab fitting into the relapse space?
Yeah, so I love this question because I'm always sort of wondering, where is elotuzumab fitting in the relapse phase, right? And we have protocols that are going on, and people have done extremely well on elotuzumab, plus other agents. And people have been going for years, just with this in, the maintenance setting as well as in the upfront setting.
Yeah, I think that's a really good, I think we would all agree that one of the sort of primary lessons we're learning today is that, like that Coke machine example that you showed at the end, Nina, there really is a huge variation. I tend to think of elotuzumab as a drug where if I'm planning potentially to for whatever reason, use essentially just a pomalidomide-based regimen based on their previous treatments or someone's comorbidities, we know elotuzumab can boost the effect of it. I tend to favor the CD38s initially, just because they have that single agent activity, so they have that extra boost effect. But I do think that there is, and again, as we've said, in a disease where we don't treat, we're not really curing patients, I want as many options as available to treat our patients. Nina, here's a question that I thought would, you can't have a discussion with two transplanters like you and I. I love how you talk to yourself as a recovering transplanter, and I'm doing less of that now with my work at the IMF. Hi, my name is Nina. I love myself. I haven't done a transplant, but is there still a role for allotransplants in myeloma?
I actually never send my patients to allotransplant in myeloma. There's never been, to my mind, sufficient data to suggest that allo is better than auto, number one. And number two, now with all our new therapies, I don't know that allo would be sufficient in the relapse setting. And in fact, I do worry about things like graft versus host disease and limitations of subsequent therapies because of a previous allotransplant. That's just my opinion. But I know that other people may not agree with me, but that's my personal opinion.
And I think it's very reasonable. I think most of the myeloma community is going there. Where I see a potential role for allo tends to be more in certain countries and regions where a lot of these new therapies aren't available. When someone has high-risk myeloma that is already showing that it is going to relapse very quickly and rapidly, and the patient is quite young. And I hate to define the word young. We used to joke and say it's young. You're young if you're younger than the transplant director. So it really has a very, very limited role. Well, at this point, Kelly, I'll turn it back to you. We're on schedule here, for which I'm grateful for the wonderful answers that Kimberly and Nina have provided. And I believe we're going to move into Kimberly's presentation on navigating the journey. But I'll turn it back to you, Kelly, if you have any other comments before we jump into that.
Yeah, quickly. Wasn't that amazing, everyone out there? Vigorous questions, vigorous answers, and we're helping you through what the next part is, navigating your journey. Remember, this is a journey, not a sprint. We have to get you together, figure out what to do, and have a good quality of life. It's easy. No, it isn't. It's very complicated, and that's why you need to be with specialists. I can't stress that enough, and nor does the IMF. You've had two specialists today, and now we're going into one of my favorite parts, navigating the journey. I've repeated myself. Please enjoy.
Thank you, Kelly. And I really want to thank the IMF for asking me to speak today. It really is an honor to be able to be in front of everybody. And I think Nina pointed out that we have a lot of analogies today. And this is another analogy when we're navigating our myeloma journey, and it's we want you to be the commander of your galactic myeloma journey. And so what we're going to talk about is giving you some tools to navigate that journey. And and when you think about navigating this, Scotty, we need more power. What does that mean? We need more power. We need more knowledge, right? So that's what Scotty was saying, when on the Spaceship Enterprise. And so I think it's important for you as, driving this spaceship to participate in the decisions, to ask for time to consider options. You don't need to make the decisions that day. Maybe you're going to make them the next day, but make sure that you have all the information. Understand what your options are. Use reliable sources of information. Certainly the IMF is one. And, use caution considering the stories of other personal experiences. Create a dialogue with all of your providers. And I think it's very important to think about your preferences. arrive at that decision together. And you're gonna hear this theme come up in the next several slides. And so, we just heard Dr. Shah and Mikhail really talk about your treatment options, but in the center of that is the treatment decision. And so based on what the clinical experiences of the healthcare providers, maybe you're at a center that doesn't do autologous transplants or CAR T. And look at that compared to, and think about the data from the research, everything that you've heard today. But what is your preference? And that really enters into the decision tree. Think about, the fact that poorly managed symptoms. Why are we talking about this? Because it really leads to anxiety and depression. It leads to social isolation. You're going to, as a result, miss some doses of therapy. There's maybe even a decrease in the treatment efficacy. But I think most important for me is when I think about the reduction in your quality of life. Keep a diary. So that you can discuss this with your team. There's many options, as we heard about just in treatments, there's many options in managing your symptoms, but we can't help you if we don't know what your symptoms are. And so it's so, so important. And, express what your priorities are. Yesterday, a couple of weeks ago, I had a patient say, my quality of life is just going to improve immensely if I can just drive. And I said to myself, well, how are we going to do that? So I worked with physical therapy. I said, let's be more aggressive with her. I thought about some of the treatments that she was on and, the fatigue level that she was having. And 2 weeks later, she drove to her appointment. So I wouldn't have known that if she didn't say, what, this is my quality of life. This is really what I need. Think about who all the crew members on this spaceship are needed for this successful journey. Right in the middle are you and your caregivers, the general oncologists, the oncologists in general, and then the myeloma specialists, extremely important. The allied health staff, such as the RN staff, maybe physical therapy, as well as maybe the nurse practitioner and the physician's assistant, if that's who you are. But your family support, extremely important. Your primary care, you need to still see them for that well baby care. Who are the subspecialists in your life now? Is it cardiology, for example? Maybe it's orthopedics. And these people all need to be part of your journey. You need to understand their different roles and how they can help sort of navigate your journey. So I love this. This is a little bit of a blast from the past, Major Tom to ground control, right? And so, we really can't, if Major Tom isn't going, if he's going to be successful, he will need to communicate with the healthcare team. So what you need to do is prepare for your mission, right? When you visit your healthcare team, write down your questions. Make sure those questions are answered. Speak up. Ask the most important questions first. I will say to patients, what's the next question? What's the next question? And are we done? And if we're not, I want to make sure that you understand. If a patient isn't asking me questions, I'm very concerned that they're not understanding or that they really want me to make all the decisions for them. Communicate with all the members. So as you sort of navigate your spaceship home, think about, how you're going to communicate with other members of the healthcare crew. Make sure you take all your medications, that you understand how to take all your medications. Follow up with all of the other healthcare teams. So a minute just to really talk about the caregivers as the essential part of the crew. They're extremely important. Who are they? Certainly it's going to be family members, but it could also be friends and neighbors, maybe members of the church. We can have shared caregiver responsibilities, but I think no matter who they are, we can't stress enough how stressful it is sometimes to be the caregiver. And we need to acknowledge that, and we need to understand that going forward. So inertia, when we think about everything's going good, the numbers look good, but we really have another mission. We want you to keep moving. We want you to adopt or maintain your healthy lifestyle. So you need to manage stress, sleep well. It all sounds so easy, but really hard, I think, sometimes to put into play. Exercise. Don't smoke. Things like things like mental health and social engagement is very important, as is sexual health and intimacy. Think about complementary therapies and how that can fit into your life, and be engaged with your primary care provider, and have regular checkups. Skin cancer screenings are very important also. And even when you're feeling well, even more, you need to continue to maintain your healthy lifestyle with your body weight, eat, balanced meals, and don't have high fat, added sugars. I sound like your mother, I know, but you're going to hear it from your healthcare providers as well as, I guess, when you're listening to presentations, but decrease the amount of alcohol consumption. And, certainly if you're going to use supplements, talk about it with your physicians. They really want to know. So I love this slide because it really talks about the Earth's gravitational fields. And so you really need to, have a different navigation strategy to maintain strong bones and muscles. And so what I always say is exercise, exercise, exercise. The benefits of it are enormous, where it's really there to improve your mental and physical health, but also in reducing fatigue and neuropathy, as well as it will help with pain. It builds a stronger immune system in some of the literature. So go for a walk. If you're going to do something crazy like a marathon, probably to talk to your providers about that. So we started off by saying, this was a galactic journey where, galactic is you need to have the knowledge to be successful. I think we all know that the IMF is here as a resource to help you learn more and to keep learning. And so as you can see, there is so much literature out there from the IMF. There's a website that is just amazing. And we have a newsletter that within Myeloma Minute that I cannot tell you how wonderful it is. Teleconferences, more and more. Kelly and I were saying before this all started, we just can't get over how easy this is, and we're reaching so many patients and people. So that's important.
Very much so. I think that we get bigger, we have more people participate in it. They don't have to drive, fly, get anything complicated. They just participate. That's a good feature about these RCWs. Right.
It is. It is a wonderful platform. And so, again, I'll close by saying thank you again for listening, and we'll open this up for questions.
Thank you. I think we have a few questions for sure. Joe, do you want to take over the questions?
Sure, absolutely.
So good at it.
Kimberly, that was you took us on quite a galactic journey over the last.
Few minutes. I told you it's the presentation of analogies, right? Today.
Yeah, no, it was really well done. I like the way Dr. Dury, of course, who's the chair of the IMF, always likes to say that he wished we didn't use the word social distancing, that we use the word physical distancing and social connectedness. And I just want to emphasize that point from your talk, that it's really remarkable how important it is, especially through this pandemic, that people feel that kind of connection. And it may not be the way we want to connect. It may not be the physical hug that we want to have, but to be able to connect with others. One of the most challenging things that we even have, and I'm sure Nina and Kimberly can both speak to this as providers, is to have to be distant from our patients, to sometimes see our patients alone, where they perhaps can't bring their typical partner or spouse with them because of, important regulations in the hospital. I'm not speaking ill of them. We do what we have to do in the regards of a pandemic, but that critical importance of finding who is within your bubble, who do you have that ability to connect with. This disease can be quite isolating in and of itself, and the last thing we want to see is a greater isolation. I know Nina and Kimberly, I'll let you both comment on that.
Yeah, so I love that point. Absolutely. And so I had a patient yesterday, his wife is always on her phone, and, we're always doing, FaceTime. And now I really feel like she's just as important as anybody else in that room. It's amazing how you can adapt so quickly to, these virtual meetings where patient is in front of you, but the family members are on the phone or, but very, very available. So it's great.
This has just been like sorry, okay, you can hear me. This has just been such a weird thing for me because I always hug my patients. Joe, I'm a hugger. And it has just been really weird. Like one of the things I got better at as a physician was being emotionally connected to my patients more, and I was just getting to my stride there, as you get more and more mature in your practice. And then COVID hit, and it was like I had to stop all of these things, that keep us connected as humans. I really appreciate virtual visits because the spouses can be there, or the caregivers, the family members, and they can't be there in person. So I do like that aspect of the virtual visit, even sometimes it's not in person.
Right. So one thing I want to just say one thing is, before we were all talking, each one of the panel members today has said, well, you know me, I'm a hugger. So it's difficult for us, right? It's difficult for us not to have that contact.
Absolutely. We got a few questions here, and I know, Kelly, we have probably another 5 or 6 minutes before we do our closing comments and video. So why don't we address a few of them? Some really good questions. Someone's asking a pretty complicated question about their own treatment and how deep a response they've had before transplant. I think we may have to pass on that question, and I could recommend to that individual that they could call the IMF info line, and we can try and help you a little bit more with that. But there is a really good question here, one for you, Kimberly, and one for you, Nina. Kimberly, for you, is there any potential harm in pushing oneself in exercise when feeling fatigued and suffering from anemia? I think this is an important issue, and I'd like your thoughts on it.
Yeah, what a great question this is. And I think that there potentially could be, because we know that multiple myeloma can involve the bones. And so, if you're going to go for more than a walk, I think you really need to discuss that with your healthcare providers.
I completely agree. I think we've also learned that there are certain activities. We think of shear stress on the spine, heavy lifting, pounding, those kinds of things. And, the usual recommendations, we tend to start slow and build up, but absolutely speak to your healthcare team about that. Nina, from another totally different angle, are myeloma patients more susceptible to non-melanomatous or even just skin cancers? The problem here is we've got myeloma and melanoma. People used to confuse them, but I think it brings up the whole question about second cancers and so on. But can you comment a bit about that?
Yeah, this is a really important issue. So we know that patients who receive a transplant and Revlimid maintenance versus no Revlimid maintenance have a small but statistically real increase in second cancers. And these often are squamous cell, as we call non-melanoma cancers of the skin, which are common in any case. This has happened to many of my patients, and I can never tell whether they have had it or not if they weren't on Revlimid, but it's really important to keep up with your PCP about that and your dermatologist. And then second of that is that, as myeloma doctors, we focus on this myeloma thing. We're not thinking about everything else. So it's really important to do your regular cancer screening, colonoscopy. Now that age was just lowered to 45, annual mammography, all of the things that you would have been doing if you deleted myeloma out of your life. You have to do those things. You have had one cancer. Cancer itself is the biggest risk for another cancer, whether it's the relapse of the first cancer or a second one. So all of those things are really important, and we would be being bad doctors if we didn't tell you to keep up on that.
Yeah, that's very, very important. There is that risk, and we see it with all cancers, and some of it is because myeloma patients are followed very closely. They're more likely to get blood tests and other things, but it's so important to watch for that. Another question here, Nina, I may ask you is, how long can maintenance therapy with Revlimid be continued? And I know we have very recent data to add to this from the Stamina study. So maybe you could talk a little bit about lenalidomide maintenance and the length of it.
Yeah, we used to think that limited Revlimid maintenance or lenalidomide maintenance for 2 or 3 years was sufficient. But actually, the more that we knew a couple of things. One, longer is better. And this has been borne out by not only retrospective data, so looking at a bunch of charts from people who did this, but actually our Stamina study, which compared different transplant sort of approaches, those transplant approaches, showed that the people who continued on their lenalidomide for longer did better. The other thing that we think, is that higher doses of lenalidomide are better for longer. That's a really tough, literally, pill to swallow, because there's no way a lot of people can handle 15 milligrams for long term. But, if you're handling 10, that's good. And if you need to reduce to 5, that's okay. I always say some is better than none. So I try to keep my patients on indefinite lenalidomide, even if it's the smallest dose, because I still think that the Brillo pad isn't enough. You have to keep doing your routine cleaning to make sure that the myeloma doesn't come back.
Absolutely. And I think maybe, Kimberly, I can engage you in this part because I know this is particularly important to me, is that despite the fact we have this evidence that lenalidomide is very good for patients, and the longer they're on it, as Nina said, they stay in remission, we have to be so careful in talking to our patients. Communication with our patients is so fundamental that we don't get to that comment I made earlier, you'll take it, you'll like it, and you'll ask for more. That it's one thing for Nina to say, look, I'm going to do this bone marrow transplant, you're going to be sick for a few months and we'll get you better. It's another thing to say, oh, you're going to be on this maintenance strategy and you might be sick for 4 years or 5 years, that we really are sensitive to any side effects that patients are experiencing, to be able to, because in general, we look at databases and these clinical trials, at least about a third of patients in the long term have to come off these drugs for toxicity or side effect reasons. So Kimberly, maybe you could just comment a little bit more about that critical importance of the communication between the provider and the patient, and so that the patient can share with them whatever side effects they may be experiencing.
Yeah, and what a great question with so many answers, right? And you want to, as we said before, you really want to have a dialogue. You want to engage the entire team, and sort of what your side effects are, what can we do to strategize to manage that. And I've had patients that can't deal with the side effects. We've decreased the doses over time. Sometimes we've changed their maintenance therapy. And I have to say, there have been situations where patients have said, I'm not going to take this. We've restaged them. There's no evidence of disease. So there are a few physicians that I've seen say, all right, we'll just watch this. That is really not anybody's recommendation, but we've done it. We listen to the patient.
Absolutely. And I guess that's maybe one of the most important, as I turn it back to you now, Kelly, I think one of the most important things we can emphasize today is that we have shown in oncology repeatedly that communication and an open, honest avenue of discussion between patients and their healthcare providers really affects people's outcomes, including their survival. So it's great to talk about all these new fancy drugs that Nina shared with us, and that they can make people live longer. But honestly, connecting with your healthcare team is fundamental to that. So I think that's a good note to leave on. And I'll turn it back to you, Kelly, to close us off and share that great video with us.
Oh, great. Well, I want you guys all to call your doctors on Monday and tell them that the IMF said so. That will keep them busy. But I really, really want to say how much I appreciate everyone being here today. I'd like to thank our sponsors, Amgen and Bristol Myers Squibb, Janssen, Karyopharm, Takeda Oncology. But with all that being said, Dr. McHale, thank you very much. Dr. Shaw, thank you very much. And Kimberly, you have too many acronyms after your name, so I'll just say Kimberly Noonan. These people have all these degrees. It blows me away.
It's crazy. It doesn't make any sense.
It doesn't. No, it does. But with all, some of that stuff being said, I want to end this with our 30th anniversary video. Just take a minute of your time. You're going to see what we've been doing, and you'll get a little bit about the IMF and what we're celebrating. So that will only be about 2 minutes. We'll be under 2 hours. And I thank everyone for participating. It's meant a lot to me. Take it away.
Patient is diagnosed with myeloma, they're not alone. They have support, they have information, they have access to things that were not there in the past.
After seeing the ravages that myeloma can cause, since then it's just been a mission to not have other people have to go through and suffer what he did.
There was a desperate need to provide information that could lead them to the best tests and to the best treatments.
It was just giving patients the voice.
We needed new treatments, better treatments. Could we cure myeloma, prevent myeloma?
Sometimes a very big advance can make only if you take a risk.
Look what happened in the survival of patients when the IMF started, and now 30 years later.
They achieved so many things in these 30 years, the focus, the energy, the synergy.
It is almost impossible to believe what has happened over the last 30 years.
The outcomes are dramatically improved, and they're going to improve more.
Because we believe that we can work collaboratively and we will cure this disease once and for all.